Okay. Yeah. Good afternoon, all of you. Thank you for giving me this opportunity. Today we will discuss about CAD in asymptomatic patients, layered testing versus one-stop shop, and ischemia test before or after angio. So here is a patient.
Christian, 1 second. Where slides not yet projected.
Slides. Slide on. Yeah. So here is a 40-year male doctor. He is non-smoker, non-alcoholic, and is non-insulin dependent diabetic. And he had a family history of father had episode in less than 60 years, cardiac event, and he came for routine cardiac evaluation. And is asymptomatic and does regular gym, basketball player. So his ECG is normal and echo study showed normal study. So he has himself done CT angiogram which showed LAD mid lesion with 40% stenosis with the calcium score 7.2. So we advised statins, but he was not compliant because there was no significant disease. And how do we advise statin and aspirin in this case?
Sir, any comments? A 40-year-old male, diabetes with a family history.
Good morning. It's a very interesting
diabetes is a
now
equivalent to
Yeah, you can carry on, sir.
So, diabetes is equal to the one heart attack type nature. I consider starting off statin is a very strong recommendation for these patients.
It's a very interesting situation because we know, I think I can just give my experiences here. We see most of the doctors, especially as this patient, we see in the periphery because of some reasons like busy schedule, and then usually the risk factors, modification, all those things are less. To be frank, sudden deaths we have seen as an examples. Orthopedic surgeon, anesthetist, almost I know about 50 number of doctors having sudden death by neglecting the asymptomatic coronary artery disease. In that, as rightly mentioned, that the CT angio for calcium score and then disease burden was seen as a borderline or mild disease of coronary artery disease. With strong family history, especially the father had coronary event maybe at the middle age, and with this type of situation I feel preferably the one should be put on statin plus antiplatelet, single antiplatelet. That is the choice of the physician, whether aspirin or clopidogrel. depends upon the tolerance, which antiplatelet the patient tolerates. Definitely, we've seen last almost more than 1.5 decade, this type of situation seeing and then treating with preventive modality, and found significant number of like reduction in the events. Because other side who are non-compliant like here, we have seen a plaque rupture with acute MI, and the coronary angiogram showed borderline disease, but plaque rupture with TIMI 0 flow or TIMI 1 flow, who required some intervention.
Yes, sir. Rightly you said, because it is a soft plaque and it is a vulnerable plaque, so it has a more risk of getting ruptured. So it is ideal to give moderate intensity statin in this case. And as calcium score is 7.2, so ideal indication is if aspirin to be indicated, if calcium score is more than 300, it should be started. So we advise moderate intensity statin. So he is asymptomatic, came for regular checkup after 4 years and asked for advice about future screening for CAD. Again, this was done in 2017. Again, he came in 2021 because for further screening of his CAD. And what shall we advise now? So ischemic stress test, invasive angiogram, again repeat CTCA, or only lifestyle modification and optimal medication is enough.
Raghu sir, do you have any comment on this? Further testing on this? Same person came for, it's same person, no?
Yeah, same person.
Same person. So I would, because this person is asymptomatic, the focus of the therapy should be on the, once again on the lipids. What did he achieve over the last 4 years? Is he in the target, did he achieve the target or not? So what is his LDL, what is his glycated hemoglobin, and what is his blood pressure control? That becomes the focus of my interest rather than checking an ischemia. Because an asymptomatic patient, let's say we do an angiogram for him, and then you have a lesion. What will we do? Are we going to stent him? Are we going to send him for a bypass surgery? Those are the groups of patients. Now with the recent evidence, we should shun doing procedures for that group of patients who are asymptomatic, and you find a lesion there and you start treating them. So we need to know the pendulum is moving more towards a optimization of the risk factors and then getting our patients onto the targets. The targets we have already discussed in the previous session.
Yes, sir. His LDL level is 72, sir, without medication, and his HbA1c is 7.2. So we advised him statins, but he was not compliant with the drug. So next he came in a asymptomatic stage for further testing. So we advised in stage ischemic stress test like treadmill we advised for this patient, but treadmill was negative for him. And we have advised CTCA in this case to evaluate the plaque again, as he was non-compliant with the drug. So now we see that there was a mid-LAD 70 to 80% stenosis with calcium of 35.2. So what shall we advise now? He is asymptomatic with LAD mid lesion, tight lesion, and he is asymptomatic. What shall we advise now?
Sir, lesion has progressed now, so how to approach it?
If the lesion has progressed now, that is where the ischemia testing happens. Now, in this particular set of patients, we rely upon the 2020 data from the ischemia trial, where we have to focus more on the progression of the disease. For example, this patient has got a significant coronary artery disease and less of ischemia. So possibly when there is a 80% stenosis, we would have to take the totality of the patient, the risk factors, the coronary artery anatomical disease, and then the ischemia disease, ischemia evaluation either by nuclear or an FFR or a IFR or whatever we do, or a QFR, whatever we do, we need to assess the significance of the lesion, and if it is significant, possibly then we can fix it. Fixing is not the major issue in this patient. It's not a tough decision, tough lesion to perform. but the decision to perform is a tough thing.
Yes, sir. So, shall we advise invasive angio with FFR, exercise ECG, nuclear stress test, or advise statins and aggressive lifestyle modification as is asymptomatic?
We need to do an ischemia testing. I think I would do a couple of tests rather than one test alone to really determine this one. FFR is good, but what happens is whenever we perform an FFR and let us say we want to leave the lesion, it has been shown that over the next 6 months they progress. So it's a tough decision to leave the patient only on FFR or only on nuclear. So I would like to take the totality of the scenario.
Yes, sir. We advised him because it is simple to see the ischemia button, so we advised the stress ECG. So he was able to do TMT, it was negative for inducible ischemia. He has done 8 minutes without any discomfort. He want to continue, but we stopped the test. And what is the next line of approach? So there was no evidence of ischemia, so he is asymptomatic. So what is the next line of approach?
Sir, if you want to choose the test, what test you want to choose? You want to choose by treadmill or you want to choose the nuclear test in this patient?
Now this is a patient where you have a single vessel disease. We all know that the pickup rate with a stress ECG is only in the 60s to 70s. The sensitivity is very low, even though if it is LAD also. So what we need to understand is your pickup rate or the sensitivity for a single vessel disease is low with a treadmill. So we need to look at other tests. Like I would have ideally performed with an angiogram to confirm and do an FFR and then possibly take up a decision there. But even as I have to put once again the caution is, even though FFR is normal today, when they followed up for 6 months, these lesions became more significant. So if then I will take a combination of intravascular imaging and FFR and then take up a combined decision. If there is a soft plaque, as doctor is telling about, is it a vulnerable plaque? Is it a soft plaque? All those things allow me to take a decision not on a single parameter.
So you want to look at the morphology of the plaque and decide.
Yes. Nowadays, I think the focus is on more on the morphology of plaque and not only on the IFR levels.
Stenosis.
Yes, sir. Thank you, sir. So his LDL was 72 and other lipid levels were in normal range. So we advised high intensity statin with aggressive lifestyle modification as he is asymptomatic. So going to the next case. So 70-year-old male, he is a senior MD physician from Karnataka, not a known diabetic or hypertensive, he is a known hypothyroidism. So 10 years back CAG was done and had a normal coronaries and is asymptomatic now. So he joined Vijayawada at Manthana Satyanarayan Raju Ashram for diet and yoga program. He started exercise in the form of swimming, noticed discomfort in retrosternal area, so suspected as angina himself and asked for cardiac help. So brought to our emergency room, this was his ECG, there was a QRBB interval MI, so emergency angiogram was done and primary PCA was done for the culprit lesion, LAD, which was mid-LAD total cutoff. So there was a non-culprit lesion in L6 also. So this is his RCA with borderline lesion in mid-RCA. And in L6 was fixed non-culprit lesion after 4 days. So his lipid levels, LDL was 82. So should we have done periodic ischemic stress test or at least before taking diet and exercise program, a repeat invasive angiogram or CTCA every 4 to 5 years or repeat periodic CAC, that is coronary artery calcium level, or only lifestyle and diet program as he chose.
Surya Prakash sir, do you want to comment on this?
So
anyway, this patient exemplifies that one angiogram, invasive angiogram especially, which is supposed to be a luminogram. So small plaques would have been missed. So that is not an insurance for you. So that is the one great lesson from this. Then how you follow up with the risk factors are there and all. Anybody wants to comment? Please.
This is a 70-year-old individual who is a physician, what I could gather, and has got only
Only hypothyroidism, sir.
Pardon?
Hypothyroidism.
Yeah, respective. There is only one comorbid condition, which is hypothyroidism, and he has had an acute MI, which has
No, sir, he is
along with
He is asymptomatic, sir. He is asymptomatic. 10 years back, angio was done. Coronary arteries were normal. 10 years back.
okay, 10 that part I have missed out. 10 years back, the coronary arteries were normal.
Yes.
Now he has a acute MI
he recently-
along with a LCX lesion, which was there.
that
The
was-
question is, how could he have been followed up? That is what the main issue, to prevent that MI, isn't it? That is the issue. The choices which you have highlighted here, whether the periodic stress test would have helped him, not necessarily as brought out. It could be a silent plaque which can rupture. A repeat invasive angiogram for follow-up, it won't have predicted an acute MI in any case, because a plaque rupture may not be picked up by doing another angiogram. Periodic calcium scoring, again, it has a doubtful predictive value as far as MI is concerned. Lifestyle and diet program obviously has to continue a person for a healthy living and a healthy outcome. So my choice that he should have been in lifestyle, aggressive lifestyle. There is no family history, there is no other risk factor. I wouldn't have recommended him as a normal person who comes to me to undergo frequent, angiogram to predict whether he's going to have an MI or not. These are certain percentage of people without any risk factor. We still don't know the genetic background, how and what has precipitates the, acute event. That's what I would rather think.
I want to
don't know
review
what-
the case, sir. This case, 70 years male physician, he was hypothyroid and is asymptomatic. He came recently to Vijayawada and he joined in an exercise and diet program. He is absolutely fine, but suddenly he had discomfort in chest and he landed here in emergency.
So the question here is whether could we have predicted that? Only risk factor which I can see here is that he is 70-year-old. That means he is in the age group which is risky. He could have had, when he joins an exercise and a diet program, has this exercise precipitated this? If this exercise has precipitated this, then he may be having a critical lesion pre-existing which could have been picked up by any stress test. That could have been advised. But here, I don't think there is any choice of doing that test, if I am not missing the question. The question is whether we have predicted this MI in this individual or not.
No, a 70-year-old physician, before going for an exercise, I think he should have undergone some periodic test like coronary artery calcium or some screening procedure like ischemia status before undergoing strenuous exercise like swimming like that. I think he should undergo.
Yes, sir. Definitely, before going to any diet or exercise.
See, 70-year-old normal coronary is 10 years, asymptomatic, and came to Vijayawada and joined Manthan Satyanarayana, whatever program, I don't know. Exactly the details, I don't know. And started some exercises and other things. And whether silent things precipitated by this program, whether we can know, if you have an idea, what type of program he has given and precipitated MI. We don't know.
He had a diet program and some type of exercises, physical exercises, like swimming and also.
Sir, 10 years back, coronary angiogram was normal. So normally in your practice, how frequently you will repeat CTCA for these patients if asymptomatic?
The frequency, as rightly mentioned, it is not mandated that every year or every 2 years we do angiogram and then find out. Anyway, rightly said, we can't find out acute MI or just our preceding findings which cause MI.
Not
We
invasive.
can never
sir,
know.
not
So
CTCA.
the only thing is modifying risk factors and lifestyle management with symptomatic follow-up and his exercise scale. There any amount of doubt, because nowadays we know most of 40% of the population mislead us. They don't reveal exact symptom. They only just try to convince us that it is an acid peptic symptoms. So that if somebody is very clear, I think clinical monitoring is more than enough instead of doing repeated angiograms.
I would like to add one more thing here. If this individual was suppose undergoing ischemia test, stress test, say every 1 year, annually or every 2 years, what it could have picked up? If it was positive, it would have shown a coronary artery disease with a LCX lesion which was nearly looking tight or similar to that. But it wouldn't have picked up anything probably in the LED territory where he had actual acute event.
Yes.
So it is very difficult to predict by doing periodic tests that whether the individual is going to have acute event or not. But yes, he could have been picked up that he's got a ischemic heart disease. That could have, he would have been subjected to stenting of LCX or other vessels, but not necessarily on the plaque. It would have benefited him that he would have got more intensive antiplatelet and other regime because of other vessel addressed and prevented an MI. I mean, that is a corollary which you can draw from this. That if he had been under periodic testing and a coronary artery disease at some other territory was detected, he would have been on statin, on antiplatelet drugs. That could have prevented him the MI where he had the LED territory.
Exercise, even exercise has to be regular and gradual, not sudden and strenuous exercise at the age of 70 years. And other factor is diet also has to be according to our customs, and it should be taken regularly. Sudden short-term dietary programs also may not be good.
That's a very important factor. Any stress can precipitate, is one of the incriminating factor in plaque rupture. So any kind of stress, how does it work on the coronary plaque? We still don't know, but adrenaline rush or other things, they do affect the coronary plaque, thin plaque rupture. They have a propensity to cause rupture. So it is quite advisable that any program which is new, which is a person is not accustomed, has to be gradually initiated.
In this case, it was mandatory. I think before he went on this protocol, he should have had a thorough cardiac evaluation done at 70 years if he's going. Definitely it was mandated, and most probably we could have prevented this MI, I think.
Yes, one more.
And nowadays, because CTCA is available and so easy, and as outpatient, it's easily preventable, I think, in this case.
Yes, sir. So one more common doubt among people are asking that before starting an exercise program, should we routinely get the cardiac evaluation done, and if so, what test we have to do for this patient? Because nowadays we are seeing the young patients who are very active in the gym.
Anybody
So should have to.
Yeah, in today's scenario, definitely we need to do periodic stress test. I am advising my patients to start screening every year after they cross 35 years in this present scenario, because lifestyle, the food that we take, the genetics that we have, they're playing a role. And most probably stress is a major part in today's life. So I think periodic stress test is good enough, and if the Framingham score is slightly high, then probably even a CT angio every 4 to 5 years is a good screening test. And probably apart from this, even bedside screening method should come into play, like B Doppler, the handheld machines, just like we are getting ECG machines now. Even for carotid and carotid Dopplers, and all these machines should come into play now for screening bedside. Then we can go for the next test. Anybody else?
Yeah, in this case, periodic stress test or before the program, it should have gone through the simple like a TMT, or a pediatric CAC could have helped him before at the age of 60 like that, at the age of 65 like that.
Periodic stress test. We couldn't get you because there was a lot of echo.
Sir?
Can you repeat, please?
Periodic stress test could have helped him before itself, because
no,
he might be having some asymptomatic ischemia or something like that.
My approach would be a little different, as I harp upon. Now we have very good ways of risk stratifying. The first case, what Dr. Raja Ramesh was showing, he was showing about polygenic risk score. The various ways of novel risk calculators are there. You have got lot of risk calculators, the ASCVD risk, plus risk calculator, you estimate the risk of the patient. Your focus is not, because this patient was clean about 10 years ago, so it's not only 72 LDL that is important. You got the 7 parameters. You take the total cholesterol, LDL, HDL cholesterol, smoking, the rest of all the things. Based upon that, it's not one risk factor which we should target, the multiple risk factors. That is why you are taking these the risk calculators. Either you take the Q risk score 3, or you take the ASCVD plus, or the European Society of Cardiology risk score. You do a objective risk scoring. That is the most important. That's what is the message, what we need to percolate. A stress test, what happens is, it gives you a false sense of security, which might not be true. For example, as I told you, at the cost of reiteration, sometimes the stress test is normal. The stress test is not the thing. You need to focus on the risk parameters. What is his glycated hemoglobin? What is his LDL? What is his blood pressure? Those are the things which are more important. Unfortunately, in our day-to-day practice, we are focusing more on the CT scan, coronary angiography, and the calcium or whatever it is. I think a fundamental evaluation of the patient is more useful rather than focusing on a very advanced test. That's what I think is the message what we need to convey.
Yeah, thank you.
Thank you very much, sir, for the inputs. Thank you, Krishnan. Now, in view of the time constraints, we'll go for the next talk by Dr. P. Avinash.
Yeah, thank you so much for giving this opportunity.
Sir, layer testing versus one-stop shop ischemia test before or after angio. We have two speakers. The first one being Dr. P. Avinash.
Good afternoon, everyone. So I would like just to go about how cardiac MRI is useful in our setting. So we are very privileged to have a MRI setup along with a very good radiologist who can give us an accurate report. I would like to touch few aspects of cardiac MRI in our center. Just to give the basics on how good it is. So with recent guidelines in intermediate risk score, we can go with two patterns. One is either we can go through a stress pathway, which will include a TMT or a stress cardiac MRI. So in that way, while trying to look for coronary artery disease in intermediate risk patients, the cardiac MRI has a role. So I'll quickly go through. So the indications of cardiac MRI are the assessment of myocardial function in ACS, myocardial perfusion, myocardial viability, severity of valvular lesions, and it is also helpful to differentiate between non-ischemic and ischemic cardiomyopathy. The right side congenital heart disease, valvular, pericardial and myocardial tumors are also well detected by cardiac MRI. The contraindications are, it is time consuming, certainly it cannot be used in a very acute chest pain setup. Breath holding has to be done in few sequences. An implanted pacemaker or cardiac device will prevent to do an MRI. Irregular rhythms or tachycardia prevent a good report. A contrast media, with an EGFR of less than 30 cannot be given. So these are the contraindications, while the indications are clear. So we have three investigations which are in parallel with cardiac MR, the ECO, the CT-CAG and SPECT, while trying to evaluate coronary artery disease patients. In ECO, there are few fallacies. The LV ejection fraction is not accurately assessed always. The LV dimensions and thickness are not accurately assessed. The LV clot are mostly missed in transthoracic echo. A viability assessment can be done with dobutamine stress, but otherwise it is less accurate. Severity of valvular lesions like MR, AR can better be predicted in CMR. The structural problems of LV, which I will discuss in a while, and the prognostic information, like after the PTCA, when a patient asks us, what is the benefit, I mean, how much am I benefited with PTCA and what is my prognosis in future, it is well described in CMR rather than echo. In CT-CAG, we can get a good coronary artery disease images, while there is need of IV contrast and there is poor tissue characterization. While in SPECT, compared to PET, viability assessment in CMR has become superior, which I will discuss in a while. So these are the MRI sequences. I would not like to confuse. There are just 5 sequences where I would like to mention the basic ones. The first is bright cine, the initial one. The second is dark FSC, which will give the structural parts of the heart. The third is most important is T2 weighted myocardial edema. So whenever there is edema which is depicted as white margin inside of the black, it means that the myocardium is injured. Next is gadolinium contrast. When we give gadolinium contrast, initial 3 minutes, what is called as first pass or early gadolinium, where we initially evaluate how the gadolinium is going into the extravascular space. Like the clots can be detected in this case. The late gadolinium enhancement is the most specific and sensitive way to describe an infarct compared to any other test, which is taken after 10 minutes. So the white one is the scar, the dark one inside the lumen is a clot. So these are the basic sequences. So in CMR, in ACS, is there any role? So when there is a patient with stable angina and with negative or positive biomarkers, we have three differential diagnoses. One is STEMI, second is NSTEMI, third is unstable angina, and the close differentials for ACS is myocarditis and Takasubo's cardiomyopathy. So how does MRI help? There is no LG enhancement in unstable angina, and in Takasubo we do not see an ischemic or coronary distribution per se. So how do we diagnose? This is a very simple example. The T2 weighted MRI which I told you is equal to myocardial edema or injury. In the first case we can see left upper, so there is an injury. In LGEs there is no enhancement. It suggests that there is no infarct. That means the lesion is quite reversible. This indicates an unstable angina or a stunned or hibernating myocardium. Whenever we say it is stunned or hibernating, it means that when we reperfuse, the ability of the heart to contract again is there. The second one is, the second lower one is T2 weighted MRI, which is showing the white margin. This is nothing but the area at risk, which is nothing but myocardial injury. The second is LGE, the infarcted area. So when we subtract the area at risk and from the infarcted area, then we get something called as myocardial salvage index. That means that the amount of the myocardium which can be salvaged. This is the difference which we calculate. So this is a 50-year-old shortness of breath patient who was under evaluation. So a CMR was done directly. We can see the early enhancement and late gadolinium enhancement. So this is how we pick up the coronary artery disease even before angio. In this patient, when angio was done, it was found to be triple vessel disease. So how do we assess viability in CMR? So after a procedure of PCI, we try to assess viability. Sometimes we do not revascularize the vessel because the presentation of ACS is already late. So how do we evaluate? The first thing which we see while checking the viability is end diastolic wall thickness. When the thickness is good, that means the area is viable. Next is dobutamine induced systolic wall thickening. When we give a stress, then there is segmental contraction of more than 2 mm, which shows a significant recovery after revascularization. The wall motion abnormalities are also checked. The most important thing is transmurality. We also know that when an MI happens, it spreads in a transmural way as a wavefront. So from left to right, if you see, depending upon how much of the wall is involved, we can see the MRI pictures. If the transmurality is nothing but if the whole thickness, at least 75% of the thick myocardium is involved, then it means that the viability is absent. So it is somewhere around 51 to 75%. The viability though is absent, sometimes we may go for some other test like we watch for RWMA and dobutamine stress sometimes. But if it is more than 75% transmurality, it means that the segment is not viable and the patient doesn't get benefited from any revascularization. So there are two other things which are specifically given by the MRI. One is called as microvascular occlusion, the second is intramyocardial hematoma. So these are the two cases. Sometimes after doing a PCI, we do not expect enough benefit from the patient. That is, the LV doesn't improve as well as the ST segment doesn't suppress. In those cases, that is called as something microvascular occlusion. So MRI also gives the clues. So how do we prognosticate the ACS patient? Once a patient has ACS, we have successfully done a PCI. So we want to understand how he is going to do in next 1 or 2 years. These are the predictors which are well given by the MRI compared to any other test. First is LV end systolic volume. The second is number of dysfunctional segments. Third is substrate identification. If the patient has a future VT, maybe that might be the source. The fourth one is recently I have discussed, that is salvage index, which will tell how much is the LV has remodeled. MVO, microvascular occlusion, is the strongest long-term prognostic predictor of MACE. The last one is intramyocardial hemorrhage. So these are the close differentials of cardiomyopathy in ACS patients. The strong one is myocarditis, where there is LG enhancement in epicardial and mid wall, infralateral and septum. In Takasubo, we characteristically see that a particular area, that is either apex, mid or base, is enlarged, and it is not confined to any vascular territory. The LG is not common, so this helps in differential diagnosis in ACS. Next is sarcoidosis. A subepicardial intense LG is found. So depending upon where the LG enhancement is there, we can definitely differentiate between different cardiomyopathies. The left upper one is non-compaction. The right one is HOCM with LGE. If the LGE is more than 15%, then it becomes an indication for ICD in those cases. And LGE in RV is suggestive of arrhythmogenic right ventricular dysplasia. So what do the guidelines say? Where can we use the CMR actually in our pathways? In intermediate risk stable chest pain, you want to go through a stress pathway. You want to do a TMT, you can go instead of TMT, you can go with a stress CMR, which is a class 1 indication. The second is whenever this patient is having intermediate risk stable chest pain with TROP positive, but you have not found any coronary artery disease. In those cases, you can look for other causes of ischemia or an alternative diagnosis I have just mentioned previously as a class 2A indication. The third one is myocarditis, and Minoka evaluation, it is class 1. At 12 weeks, an MRI can be done in post ACS with LV function of less than 40 after complete revascularization and OMT to evaluate the need for primary ICD implantation. So thank you for patient hearing.
Sir, one question. Sir, how commonly you will evaluate for myocardial viability in a delayed presentation MI? If so, what modality would you like to choose, whether it is MRI or PET scan or stress echo?
If it is beyond 48 hours, I almost 70-80% I will do a viability testing. Unfortunately, I do not have so much of expertise support with cardiac MR. So I have a good nuclear physician with whom I collaborate, and then I do a technetium system maybe for a lot of my patients. It's economical and not claustrophobic. That is the reason what I do.
Any other comments, sir?
What is the time duration like after MI? When do you want to do cardiac MRI?
No, why I don't do cardiac MRI is I do not have a expert colleague to support me with the interpretation of the test and for discussion and all.
Sir, any concessions on at what time after the post MI we have to do the cardiac MRI for assessing the viability? It is at the end of first week or second week. Post MI, when we have to do the cardiac MRI to assess for the viability.
Thank you for giving me opportunity. I am Dr. Satyanand, I am a general physician. We had a case where an elderly lady who can't do TMT, she came for evaluation of breathlessness. 10 years back, she has undergone CT and coronary angiography, which was normal, but she spent almost about 15 days in ICU. So she cannot, when we asked, we advised to undergo coronary angiography or CT CAG, she is refusing, because obviously for the obvious reason. Does the MR help in such situation? My question to Dr. Avinash.
Sir, you mean MRI for ischemia testing?
Yes, exactly.
Yeah, right now we are discussing about...
Not only that, even delineating the vessels and seeing anything, plaques or anything. Is there any possibility of MRI helping in such a clinical scenario?
Avinash, MRI ischemia testing.
So actually, sir, with reasonable amount of confidence, we can say in echo itself and how much is the patient having an coronary artery disease. But if we cannot get a proper echo, or if you are not confident about the echo findings, then definitely CMR can be done. So, but there are problems with CMR. You have to take the patient, if he is on ventilator or something, then it becomes really difficult to shift the patient. It is not possible. And also, what are we going to gain apart from that? So, once we diagnose that the patient has an ischemic cardiac disease, eventually we may have to go for angiogram. If there is no specific lesional or anything, then maybe
Avinash, close. Keep the mic close.
I think, sir, in some sequences, gadolinium is not required. Actually, sir is there here, radiologist will tell me. Some sequences, gadolinium is not required, sir. If we want to give gadolinium, creatinine should be good. In less than 30 kilograms, we cannot give gadolinium also. So, if there is renal failure, we can't use. Without gadolinium, we can take the help of T1 and T2 mappings.
Oh, Dr. Satyanand, if there was a lot of echo in hearing what exactly is required, there is a patient who is sensitive to contrast and also unwilling to go for invasive evaluation. Is that the question?
Exactly. Yes, sir. Yes, sir. Exactly.
So, firstly, I think elderly patient and all, we do stress evaluation by stress echo. Stress echo, I think he was also highlighting, that is number one. He or she can be subjected to stress echo. If the stress echo definitely shows regional wall motion abnormality during stress, then obviously there is no shortcut then to do an invasive angiogram. We have to convince her. Okay. I don't know, MRI is coming up in a big way, like he has pointed out some of the new indications which have come as class 1, class 2, that can also give you functional idea and ischemia and other thing. But as of now, we are doing only stress echo for these people who are unable to perform stress test, or go for nuclear medicine, that also is a evaluation. So these two tests can be safely done. If both of them are showing positive, then she has to be convinced to undergo angiogram and taking all precaution of contrast related, hypersensitivity if she's giving that kind of history.
Thank you, sir.
There won't be any shortcut to that.
Thank you, sir. Thank you.
Thank you. Then I would like to call our next speaker, Dr. Shahnaz, to take the remaining part of the same topic.
Good afternoon all. I'm going to present two case scenarios post-MI. So this is case 1, 63-year female. 1 week prior, she had a history of chest pain associated with palpitations, 1 episode that is lasting for 2 hours. She visited a local doctor where the ECG was done and revealed evolved anterior wall MI, for which she was referred to higher center, but it has been like 1 week after the advice she had been presenting here. And the echo was showing there is regional wall motion abnormality with mild LV dysfunction. She is diabetic, hypertensive and hypothyroid. This is the ECG that is showing evolved anterior wall MI. And angiogram was done, which revealed left main coronary artery disease 50% lesion and double vessel disease of proximal LAD 80% and ramus 80%. So, next, how do we approach this case?
Sir, 1 week post-MI, do you want to proceed with the revascularization based on the angiogram, or we want to assess for the viability, sir? 1 week post-MI. Angiogram, you said. Can you just show again the angiographic views, sir? Any comments?
What is his symptomatic status,
She
Shahnaz?
is asymptomatic as of now, sir. She is asymptomatic.
Asymptomatic. So in this situation, I think evolved MI, and the picture here, I'm not sure, the LAD lesion doesn't seems to be too tight. The ramus is a good sized vessel and having, I think, looks like 80 to 90% lesion. But if he is asymptomatic, and I think at this stage, post-MI evolved, functional evaluation is mandatory, especially the stress may be scanned to see the inducible ischemia and then further revascularization if positive.
So in this case, we had done a cardiac MRI, sir, which revealed the viability of LAD territory was there, and even the thickness was preserved, and late gadolinium enhancement was also less than 50%. So this patient had been taken for, because left main lesion was also there, and she is diabetic and underwent CABG with 2 grafts, sir, and she is doing well and she is on follow-up. Now I would like to present the second case. She is 61-year female, complained of breathlessness since 5 days. She is hypertensive, no orthopnea or PND, and ECG revealed 3rd degree heart block with poor R-wave progression with T-wave inversions in the precardial leads, which was like suggestive of evolved anterior wall MI. And echo-wise, there was regional wall motion abnormality with moderate LV dysfunction. So now she is diagnosed to be evolved anterior wall MI presented with congestive heart failure and complete heart block. And for her coronary angiogram was also done, which revealed single vessel disease, LAD mid 70 to 80%, 2 tandem lesions and distal 50%.
So now having complete heart block and LV dysfunction, how to proceed in this patient?
This patient already has a evolved MI, and we are evaluating LAD which is showing tandem lesions which are significant. Now the other question is the patient had presented with recent onset shortness of breath, which has been found to have complete heart block. So the main precipitating factor is first complete heart block, which may have taken away the atrial boost to the ventricle, and the ventricular function has gone down and the patient has gone into heart failure. She requires first immediate stabilization and maybe a pacemaker support, where she has a complete heart block, and evaluation of LAD territory if it is showing, because it's an evolved MI, if it is showing reversible ischemia, then possibly intervention is possible because of 70 to 80% lesion, it can be tackled. So I'll go stepwise, because firstly you have to evaluate the LAD territory viability, and secondly address the complete heart block. The two may or may not be linked. Heart block may have occurred because of ischemia. It may have been, considering the age, may not be associated. Most likely it could be related also. I hope the right-sided circulation is fine, right coronary artery is fine, because it's just shown only the LAD territory.
Think, sir, we were also in the same dilemma that it was like a present MI that is causing complete heart block, or it was the previous evolved anterior wall MI. So we also underwent, like first coronary angiogram was done, which was showing LAD territory lesion. And viability scan was done, sir, because after keeping a pacemaker and all, the evaluation of viability through MRI will be difficult. So we had gone through first viability scan, which revealed preserved thickness, and even the myocardial function wise also it's viable. So the patient had underwent first, like PPI was placed first, then after revascularization was done. This is the angio one. This is post PCI, the revascularization was done.
So
post PPI.
Both these cases highlight the role of your MRI in telling us the viability of a territory, whether to intervene or not. So it's a very good, useful, utilization of MRI, and in deciding whether to intervene in a territory which is infarcted.
Thing is, sir, in this patient, even after keeping a pacemaker, PPI, it has been for the same lesion after revascularization also for 2 to 3 months. She was having the paced rhythm. Now at present, like 1 week back, we had followed up the case, and it is like intrinsic rhythm has been, again she had been on intrinsic rhythm as of now.
So the complete heart block has recovered?
Recovered.
That suggests that it was ischemic only.
But it took time, sir. Over 2 to 3 months it has been. So I would like to present the similar angios where MRI we would like to whether to revascularize or not. in a dilemma cases. Both the cases are showing middle AD 90% and this is also showing middle AD 90% with diffuse distal lesion. But doing cardiac MRI, the one which is on the right was showing like myocardial enhancement which was less than 50% and the thickness was preserved and 2 non-viable segments with all other segments are viable. So there is like good probability of return of function, whereas the left hand side MRI was showing there is a transmural enhancement of greater than 70% and there are 5 non-viable segments were there and there was like poor probability of return of function. Even the thickening of the apex and LAD territory, you can make it out in the MRI dynamic image. So this is both the lesions were the similar, whether to revascularize in a case of evolved MIs, like post MI, there is a period lagging of 5 days to 1 week and more. So take home message is like the family physicians play an important role in bridging the time delay from the early diagnosis to early treatment of cardiac emergencies. In a cardiac patient, in an MI patient, time is nothing but muscle. So utmost important is early diagnosis in cases of atypical presentations where angina equivalence will be there, where only like exertional dyspnea or profuse sweating 1 or 2 episodes which are like very much vague complaints. So the angina equivalence should always be kept in mind so that early diagnosis of MI will be diagnosed early and the patient gets an immediate care for their cardiac emergencies. Thank you.
Thank you, Dr. Shahnas. So that concludes our session. Anything you want to add on this session, sir?
I would like to, congratulate the team for bringing so many very interesting cases, and all of you have digged your case resources. One thing which one of our earlier colleagues was telling about the role in Takotsubo is one thing which we see. I would like to share one patient who is right now, whom we did an angiogram, the limitation of an angiogram. Angiogram was done last year, which was normal. Today he gets admitted with heart failure and the ejection fraction was last year was normal. Now he comes with severe LV dysfunction. TROPS are 7,900. Pro-BNP of around 25,000. So these are, and severe LV dysfunction. So these are the types of patient. The angiogram, even if we do now also it might be normal. But what we need, and ECG doesn't show any acute ST elevation MI. So these are the groups of patients which we are seeing nowadays more commonly, whether they represent a plaque erosion or whether they are a Takotsubo. Differentiation of these two will become very difficult. So plaque erosion might be presenting as a non-ST elevation myocardial infarction. So that is the where our cardiac MRI plays a very important role, because the role of secondary prevention, whether we need to label it as ischemic heart disease, whether we need to label it as Takotsubo, whether the node for a pacemaker, ICD, all those things are totally different. So that is where I think cardiac MRI has one more very important role. So be vigilant about finding those patients. I had this week two similar patients, two patients with different presentation, but with akin presentation, with the same type of elevated TROPS, normal ECG and angiograms normal, with very high TROPS.
Thanks for sharing your experience, sir. Now I request Dr. Srinivas Prasad sir to hand over mementos for the panelists and moderators and the speakers, sir. We are concluding this session and we will proceed for the next session.
Thank you.
Yeah, now we will disperse for half an hour for lunch break, and then after the lunch, post-lunch sessions, we'll resume. Thank you.